So this seems like a very fitting topic to be discussing right after lunch, right? So we're going to talk about feeding difficulties and aspiration in the context of CHARGE syndrome. So just like with everybody else who's talked, if there are any questions or you have any comments as we go through, please don't hesitate to interject, raise your hand, jump up. We'll try and keep it pretty informal. This thing's not working, Joe. You joked that it wasn't working, but now it's really not working. All right, well, we'll do it this way while I look at it. Okay, I don't have anything to disclose. So we'll just start by covering reasons that we see so much dysphagia in kids who have CHARGE syndrome. So we'll look at some of the anatomic, developmental, and behavioral considerations, and we'll talk a little bit about aspiration and then some management options. This is a lot to cover in an hour, so anyway, some of it we'll kind of gloss over some things, so if you want more information on any particular topic, let me know. You testing it? Yeah, see nothing. Okay. All right, so I'm tethered to the podium now, it looks like. Okay, so when we talk about feeding difficulties in kids with CHARGE syndrome, at some point over the course of their lifetime, up to 90% of kids with CHARGE have some sort of feeding difficulty, right? It's pretty common to see failure to thrive, and we see aspiration in as many as 2/3 to 3/4 of the kids who have CHARGE syndrome. But we know it can improve over time, right? We've seen testaments to that, in this room, and many of you have kids who would fall in that category. And as we look at the reasons for it, there are really multiple things that factor in. Right, so when we look, and there are no huge studies of this yet, but they'll be forthcoming, don't worry. But looking at a group of 39 kids with CHARGE syndrome, in this particular group, 92% of them required NG feeds, nasogastric tube feeds, at some point in their lifetime, right? 77% of them in this particular group had a G-tube for at least some or all of their nutritional needs. And at the time this study was done, 62% of them were actually still feeding tube dependent in some capacity. And when you look at that same group, by the time these kids got to school age, less than half of them were eating exclusively by mouth. So they may be taking some by mouth, but they were not entirely orally fed. And that kids who had either aspiration issues or who had bad reflux, they had a higher rate of ongoing needs for some sort of tube feeding, some sort of supplementation. And in this particular group, it was felt that cranial nerve dysfunction was really a significant contributor. So as we look at some of the major considerations, as we look at feeding difficulties, we're going to go through kind of each of those stepwise to try and make sense of why there are so many different factors that feed into the difficulty with feeding in kids with CHARGE syndrome. Right, so it's really well known that kids who have CHARGE syndrome have very high rates of cranial nerve abnormalities, right? And we all bandy that about, but we're going to talk specifically about how the cranial nerves influence feeding in these kids. So pretty much, at least 90% have some sort of cranial nerve abnormality. Right, and how is that relevant to feeding? Well, we know that it's going to impact feeding development. They'll start with weak sucking and chewing because of the cranial nerve issues. It creates swallowing difficulty, it worsens reflux, and it sets kids up for aspiration. And all of those things make feeding really hard. So we're not going to talk about all of the cranial nerves, but just the ones that are really relevant to feeding. So when we look at cranial nerve 9, right, so this is what we call the glossopharyngeal nerve. It provides a lot of sensation to our pharynx, right? So the back of our throat, our palate, and the posterior third of the tongue. And if your sensation doesn't work in those areas, you're going to have a really hard time moving food or moving a bolus through your mouth. And it also provides some of our sensation of taste. And again, if you have no sense of taste, you lose a lot of the motivation to want to eat. When we look at cranial nerve 12, cranial nerve 10, I'm getting ahead of myself. Cranial nerve 10 does a ton of things, right? It's got a big motor role, so it's going to control a lot of the muscles that we need for swallowing. Both, again, those muscles in the back of the throat, but also the muscles that help control the movement of the larynx or the voice box. It also provides sensation to the larynx. And if you have abnormalities in either of these nerves, you can't coordinate your suck-swallow, right? You can't move food to the back of your mouth to swallow. You have gagging issues, and because your larynx doesn't have the appropriate sensory input, you have aspiration issues because when stuff goes down the wrong way, you can't sense it, and so kids don't have the cough to trigger, to clear it, and stuff then gets down into their lungs, right, which is a big issue. Cranial nerve 7, right? Cranial nerve 7 is the nerve that really, it's one of its biggest jobs is to control the muscles that move our face. Okay, so if the muscles that move your face are not working, it creates issues with chewing. It creates issues with tone, just with your lips. And some of these muscles also contribute to the movement of the larynx and some of those structures that you need in order to swallow safely. The other thing that cranial nerve 7 or the facial nerve does is it's the sensory input to the front part of the tongue. So again, if that input's not there, you lose a lot of the motivation, right? We all wanted to eat those cupcakes, not because the cupcakes are good for us, but because they taste good. One of the other things that we see with cranial nerve 7 is it also does some of the innervation to our salivary glands, which become relevant a little bit later on. And then the often overlooked cranial nerve 1, this is the nerve that lets us smell, our olfactory nerve. Most of our sensation of taste comes from our ability to smell, right? So if you couldn't smell those cupcakes, they didn't taste very good, and then you probably didn't want to eat them. And we can see issues in the olfactory nerve in up to 80% of kids with charge. This one can be really hard to measure, really hard to tell if it's there, but it really makes it hard to learn how to eat because you don't want to eat if you can't smell. And it also, further down the line, when kids are responsible for feeding themselves and looking after themselves, it can create safety issues. You can't smell rotten food, you can't smell smoke, so it's got some additional negative impact. So when we kind of move on to the structural abnormalities that are commonly seen in kids with charge syndrome, any of these things, if present, can contribute to feeding difficulty, right? So choanal atresia, right? This is present in about 50 to 60% of kids with charge, can be one side or both sides. It interferes with breathing. Anything that interferes with breathing interferes with your ability to eat by mouth. Right? That's especially true when you're an infant, but remains true even as kids get older. If you really can't breathe through your mouth, it makes coordinating swallowing, breathe through your nose, it makes that coordination of swallowing much, much harder. As we look at some of the other structural abnormalities, right, you can see in these pictures how these things would pretty obviously interfere with your ability to be able to eat, right? So cleft lip, cleft palate, not quite as common, really only in about a quarter of kids, but especially again when kids are babies and they have either of these things, it interferes with their ability to generate suck, right? So you can't breastfeed very easily, can't bottle feed very easily. You have to modify how you feed kids who have a cleft lip and palate, and it can also interfere with swallowing function. There's some other structural abnormalities that can really interfere with a baby's ability to eat from the get-go, right? So tracheoesophageal fistula or esophageal atresia. Again, not as common, but when they're present, right? So the TEF is when you have that connection between the trachea and the esophagus. And for those of you who haven't had a child with this, what you're looking at in this picture, this is actually the airway. So the camera is in the airway sitting here. This is the opening down to the right and the left lung, and then this little hole at the back is a communication between the trachea into the esophagus, right? If you've got this direct communication between your esophagus and your trachea, anything you swallow is going to come through that hole and bathe the lungs, right? So with that present, you can't safely feed. And if you have esophageal atresia, your esophagus is not completely formed, which would prevent you from being able to swallow. And so these kids can't feed orally from the get-go, and we know that when kids don't feed orally from the get-go, it makes learning to feed down the road much, much more difficult. So some other structural abnormalities that we see really commonly in kids are some abnormalities of the larynx or the voice box, right? So this is where I spend a lot of my days, is in this part of the world, right? So if you look at the top picture, and I apologize if I know the pointer only shows up on one side. This is a normal voice box, right, on the top. And the big things that we see when you compare a normal voice box to the voice box or the larynx of a child with charge syndrome, these little cartilages at the back, they're called the arytenoids. And any of you who's ever had a scope in the OR has probably heard all these terms before, right? So these are normal arytenoids. They sit at the back. They help kind of with vocal cord movement. We see in kids with charge syndrome very commonly, these arytenoids are really big, they're really bulky, and they sit sort of tipped forward. So when you're looking at this voice box, you can barely see the vocal cords as compared to this one where you see them very clearly. Right? Some of the other things that we see is that they have that we'll see commonly shorten what we call Aryepiglottic Folds, right? So that's this little band of tissue right here. You see it really nicely in that larynx there. It's a little harder to point over here. So that's the Aryepiglottic Fold. And in the kids with Charge syndrome, oftentimes we'll see that that fold almost seems non-existent because it's so short. And the net result is that it really squashes that space, that opening into the voice box. The other thing that we see really commonly is, again, this is a cranial nerve issue, is that the voice box doesn't have the proper sensation, right? So normally, if you swallow and it goes down the wrong pipe, you have a big coughing fit, right? Because as soon as liquid hits this space right there, it triggers a cough. If your sensation's not intact, the liquid hits there, you don't get a cough, so the liquid just keeps going right on down into the airway. Other things that contribute is upper airway obstruction. So these are things that we see pretty commonly. This is a picture of adenoids, right? So these are just normal, every run-of-the-mill adenoids. It's looking actually through the mouth, and all of this big lump of tissue, normally you're supposed to be able to see two openings here, which would be the back of the nose, and you can't see it. So you're not getting any airflow through the nose. It's similar in a lot of ways to a child who has choanal atresia. Big tonsils, right? So again, here are your tonsils in the back of the throat. If these are big, you know, this increases work of breathing, can worsen the risk for aspiration. And again, if you start combining all of these things, big adenoids, big tonsils, a larynx that's a little bit crowded, and this is a pretty crowded looking larynx, right? So you can't even begin to see an opening into the airway in this child. You combine all those things and you start looking at potential need for a tracheotomy. Some other structural abnormalities that can contribute to feeding difficulties, congenital heart disease. All right, so we know a lot of kids with Charge have congenital heart disease. We know that a lot of kids with congenital heart disease, even if they don't have Charge, have really significant feeding issues, really high rates of trouble feeding. And again, a lot of times it's because in that early period of life in infancy, their heart issues prevent them from being able to feed normally. And by the time they're through that, they haven't been eating normally, and you have to try and get them back up and running. When you talk to the cardiac folks, there's a lot they still don't understand about why kids with congenital heart disease have so much feeding issues. There's some thought that it may be related to what they have to go through, especially if they go on bypass to have their heart defects repaired. Sometimes vocal fold paralysis will feed into this, right? If you have a vocal cord that's not working, it further complicates swallowing and increases your risk for aspiration. An additional factor that we see in a lot of kids with Charge is the presence of a trach. All right, so when you look at adults and kids with trachs for any reason, there's a pretty high rate of swallowing dysfunction, and as much as 50 to 87% of all adults, right? And this is all comers with a trach, and we can't really take that information and generalize it to kids, and it's really not been very well studied in children, but we do know that kids who've had a long-term trach, especially those who've been NPO, right, so those who don't eat by mouth, they're at much higher risk for developing feeding issues. Lots of theories as to why this is the case, right? So when you've got a trach tube here in your neck and you go to swallow, normally when we swallow, the whole voice box area elevates. It's part of our swallowing function. When you have a trach tube sitting right there, the voice box doesn't elevate the same way. It's sort of tethered or tied down by the trach. That's felt to contribute. There's also some concerns at the pharyngeal phase, right? So the movement of the back wall of the throat can be affected, especially if you have a cuff on your trach. You get some desensitization of the larynx, right? So you lose some of the sensation because air's not moving through it anymore. So you don't have that kind of same sensory input. And then again, you get some discoordination of the closure. Normally our voice box, when we go to swallow, the vocal cords close. If you're not using your voice box to breathe, which is what happens when you have a trach, some of that coordination bit gets lost. And then there are also just some physics principles that come into play when you have the trach. So when we look specifically at pediatric patients with trachs, there are probably, again, multiple factors that contribute. The trach itself, the reason they got trached in the first place, and then some comorbidities, right? Kids with trachs, they're more likely to be premature, more likely to have some neurologic issues, and have some developmental delay, and all of those things can contribute to swallowing dysfunction. That's my daughter, a couple years ago. We trached some baby dolls at home for teaching purposes, and she's like, Mom, I like this one. I'm just going to play with it for a little bit. So Passy-Muir valves, and I'll just touch on these briefly, right? So if you've got a child with a trach, you may or may not have encountered a Passy-Muir valve or a speaking valve. They are basically a one-way valve that lets you breathe air in, but forces air up and out through the voice box, right? So it's kind of the best of both worlds. And in some folks, this can improve swallowing, decrease aspiration, and can help with management of secretions. And so when we look at that feeding difficulty and the role of a Passy-Muir valve in this is, in adults anyway, it's been shown to significantly improve swallowing function. Just by kind of altering the physics, and it more mimics what happens when we swallow without a trach tube. So if your child has a trach and nobody's talked to you about a Passy-Muir valve, not all kids are candidates, but it's at least worth asking to see if your child is, because sometimes you can see there can be some improvement in dysphagia. I say that and then follow with this slide that shows that there's really no evidence to support this. There's been a single study of 12 patients and looking at the role of the Passy-Muir valve in swallowing, and it showed no difference. That being said, our pulmonologists will swear up and down that it makes a big difference, but that the science isn't necessarily there to support that. One of the other big things we see in kids with CHARGE syndrome, especially as they get a little bit older, is that they have a lot of behavioral feeding issues. And I am by no means a behavioral expert on any of this, but when you look at the literature, and again, these are all studies of relatively small numbers, but every child that was looked at in this particular study had some sort of difficulty chewing, and they all needed pretty close supervision during meal times, because they would do things like overstuff their mouths or pack food in their cheeks. And these are all things that can be more of a setup for aspiration. All right, so when we talk about all these feeding difficulties and swallowing difficulties, best way to sort of explore the degree of difficulty is through a multidisciplinary evaluation. And this is one of the principles that our clinic here is built on, right? When you come through, if you've come through our center, you meet more providers than you ever thought you would. And it's not just the doctors or the surgeons that you encounter, but when we do a swallowing evaluation, it always involves a speech-language pathologist, usually an ENT, oftentimes a pulmonary doctor, and in some places, not so much here, just the way we're set up, but it can be a physical or occupational therapist that's part of the team for a swallowing evaluation. And really the goals when you're looking at this are to determine safety of feeding, right? Can your child safely feed? What's their risk of aspiration? Are there compensatory strategies that can be employed to allow your child to safely feed orally? Are there diet modifications that can be employed, and what are the therapy recommendations? And as we kind of walk through the evaluation for this, we start, there's an oral motor evaluation, right? And this is hugely important in kids with CHARGE syndrome for a lot of reasons. And one of the big things is just the sensory input, right? So keeping in mind, again, all those cranial nerves that we talked about, we'll see in some cases hypersensitivity, right? So these are kids who are real sensitive to texture, right? So they'll eat one texture but not another. Avocado is a big one in the adults in the room. I've come to learn. I don't know how avocado came up so much, but there are a few in the back who just can't do the texture, right? But that texture thing is pretty common. But then there's also hyposensitivity, right? So they can't feel that bolus, that they take the bite of food and they can't feel it as well as they should to move it from the front of their mouth to the back of the mouth. And if you can't get it from the front to the back, it's never going to go down. And then again, sort of that impaired tactile discrimination, right? So not necessarily being able to discern between different textures if they're in the mouth at the same time, and that makes swallowing really hard. So the other part of kind of that oral evaluation is those oral pharyngeal skills. So what is the oral anatomy? Are there issues with the anatomy that are going to impair swallowing? Is there a unilateral choanal atresia that's not been repaired yet? That can impact swallowing. Are there huge tonsils or huge adenoids? Also can impact swallowing. And then looking at just the patterns, right? Is there symmetry? And this is again where some of those cranial nerve issues, if you've got a unilateral facial nerve paralysis, you don't have symmetry in a lot of the movement of the face. And you can then have issues with, tongue protrusion, jaw movement. All of these things will factor into just the pure motor skills of being able to swallow. And then starting to look at sort of the developmental capabilities and the developmental skills that are necessary to kind of move through the progression of swallowing. The funny thing about swallowing is that for people who do it without any impairment, we do it without thinking about it, right? And so it's sort of difficult to imagine, well, gosh, you put it in your mouth and you chew it up and it's gone. But when there's any disconnect in the whole process, swallowing is a really, really difficult thing. So that's kind of the one part of the evaluation. The other is what we call an instrumental evaluation, right? So these are the tests that we do to look at the safety of swallowing. And again, for most kids with Charge syndrome, they've done at least one of these, if not many of these, over the course of their lifetime, right? And by doing these, we're looking to answer a specific question, all right? And the test that we choose is going to be chosen based on the question we're trying to ask. For a lot of kids, we end up doing more than one or doing a couple different types because the tests are really complementary, right? And the two big things that we do are a video swallow study, which is also called a modified barium swallow, depending on where you get your care. And this is a collaborative study done between a radiologist and a speech pathologist. A video swallow study is considered the gold standard for assessing dysphagia and aspiration in children. And what we're looking for in this is the child able to protect the airway? If they're not protecting the airway, why are they not protecting the airway? The study that we use perhaps even more commonly in our population here, especially our kids with Charge who don't eat anything by mouth, is what we call a FEES study, right? So this is a fiber optic or functional, depending on who you ask, endoscopic evaluation of swallowing. So this is where an otolaryngologist takes the little tiny camera, sticks it in the child's nose, while a speech pathologist feeds them different textures of things. And then with the camera hovering in the back of the throat, we actually watch what's happening during the swallow. The nice thing about a FEES study, especially in kids with Charge syndrome, is that it also lets us assess if the vocal cords are moving, which we can't do on a video swallow study, right? And those vocal cords, lots of reasons that they might not be moving properly, and knowing if they move is hugely relevant for lots of different things, lots of different management decisions. So some of the biggest things that we're looking for when we look at swallowing is secretion management, right? So not just can you swallow food or can you drink from a bottle if we give it to you, but what do you do with your own saliva? Aspiration, and then the body's ability to protect that airway, right? So do you cough when stuff goes down the wrong way? And those are probably the three most important parts of this assessment. Additional little side tests, this is a nice do-at-home test if you have a child with a trach. We call it dye testing, where you basically take some food coloring, put it either in the food the child's eating or even just a drop or two on the tongue if the child doesn't eat by mouth. And then if you end up suctioning it out the trach tube, you know it's going down the wrong way. It's not the most reliable test, but it's kind of a quick and dirty way to assess is stuff being aspirated. All right, so when we talk about aspiration, it says it's playing the video. We even tested this. Oh, it's playing it up there. It doesn't play on my screen. That's funny. So this is what a FEES looks like from the inside. All right, so this is the camera hovering above the voice box, right? So you can see the voice box right there. And then as the child swallows, you see that material kind of sneaking down the side, all right? So you can aspirate anything, liquids, food, saliva, or stuff that you reflux up from your own stomach. And one of the things that we're looking, one of the things that would make us think you're aspirating is coughing and choking with feeds. Great indicator if you've got sensation to your voice box. If you don't, you won't cough and choke when you feed because it may just silently be slipping down into the airway. So all along I keep talking about aspiration, right, and feeding difficulties. And even though feeding difficulties of all variety are impactful in the overall development, the part that really worries us, the part that we focus on a lot, and if you've come through our center, aspiration is like the #1 thing on our list of concerns in kids who have feeding difficulty. It's been observed in probably, like I said, about 60% of kids with charge, either on their video swallow study or on that FEES examination. And it's a big problem. So let's talk a little bit. I mean, you can clearly aspirate stuff that you put into your mouth, right? So if you're drinking or eating, it can go down the wrong way. But one of the things that oftentimes gets underappreciated is aspirating your own saliva, right? Which can be just as problematic and just as unhealthy for the lungs. So when we talk about saliva, over the course of a day, the average adult makes 1 to 1.5 liters, right? So think of one of those big 2-liter things of soda. And over the course of the day, you make at least half of that, right? That's a huge volume. And that saliva gets made by kind of 3 sets of major salivary glands. Our parotid glands, which live here in our cheeks, our submandibular glands, which live underneath the jaw, and then our sublingual glands, which live underneath the tongue. And those are all paired sets, so those are like the 6 big salivary glands. And then you have hundreds of little itty-bitty tiny ones that just line your entire oral cavity, right? And saliva is a good thing, right? It's really important in our function, right? It keeps the inside of our mouth moist. It lets us both moisten and cool off food. It helps actually start the process of dissolving and digesting food. It buffers acid, which is important for protecting our teeth. And it has some antibacterial properties. So saliva is not a bad thing unless you have too much of it, right? So why do we see then drooling and aspiration? Where does that come from? Again, all of these factors we've talked about. It can be a motor control issue. You can have an inefficient swallow or decreased frequency of swallowing. And this is a big one. And a lot of our kids with CHARGE syndrome, they don't necessarily generate a spontaneous swallow the same way that you or I do, right? If you just sit here, you just finished eating, your salivary glands are all stimulated, you've been swallowing constantly throughout this to swallow your own saliva, and you don't realize it. If you don't do that spontaneous swallowing, all those secretions, that liter of saliva that you create over a course of a day, it's got to go somewhere. So it's either going to come out the front in the form of drooling, or it's going to go down into your airway because it's got nowhere else to go. Some of the other things that we can see contributing: developmental delay, structural problems, so all these same things we've talked about. One of the key things to remember is in kids who are either have too much drooling or aspiration, they're not making too much saliva. It's not an overproduction problem. It's just a management problem. They don't do the right, it doesn't have the right pathway out. So they're not making more than the rest of us. They just aren't managing it the same way. So when we look, again, this is just looking side by side at the difference between a VSS and a FEES. And you can see when you look at these kind of the complementary nature of the two, right? So the video swallow study here, as you swallow, it's a little, I can't freeze frame it up there, but you can see there's a little blurb, a little bit of the dark stuff as it goes down. Play it again, going down each side. Whoops. All right, maybe it will play again. And so as there's kind of the bolus of the dark material, and as the swallow happens, you can see a blurb of it going down the front and the back pipe, right? That means some of it's going where it's supposed to, and some of it's going down the airway, which is what we don't want to see happen. And then the FEES, again, lets us get that direct look from the inside at where things are going. So when we look at kids with CHARGE syndrome, I think they should all eventually play. These are three very different appearances of the FEES. The one on this side is essentially normal, and all 3 of these kids have CHARGE syndrome. The one in the middle is a little bit of moderate impairment. And then when you look at this last one, if it'll play, it's not the best quality video, and it's being a little stuttery for some reason. But in that last one, everything is so crowded. All you see is secretions because they're just pooled back there, and they're all just kind of pouring down into the airway. So as with so many things that we deal with in CHARGE syndrome, there's a huge variety, right? Kids who can swallow just fine, and kids who can't manage their own saliva in the least. So I keep coming back to this idea of aspiration and why we care, right? So in kids who can't manage their secretions or who are struggling with that part of it, especially if they have a trach, you do see frequent suctioning, although you'll see this sometimes in kids without a trach where parents are having to suction the oral cavity constantly because the saliva is just pooling there. You can get noisy breathing, right, where the kid just always sounds wet. They've got that juicy sound to them all the time, or they're choking on their own secretions. And then we start to get into the things that are even more troublesome, the recurrent pneumonias, right? If all that stuff's going down the airway and causing infections, this can lead to oxygen requirements. This can lead to increased vent requirements. It can lead to intubation. And the bigger issue is that over time, it can lead to long-term damage to the lungs. And the lungs are a really unforgiving tissue in that once they're damaged, they don't come back. So when we start to lose lung tissue, you lose that capacity going forward. And so it's a big deal, and this is why we perseverate on it so much. So when we think about aspiration in feeding, just because your child aspirates doesn't mean they can't be orally fed, right? It's going to depend really on the severity of the aspiration, and oftentimes we can either use thickened feeds or modified swallowing techniques and still allow them to do at least some oral feeding despite aspiration. In some kids, oral feeding is just not an option, right? And you end up talking about either NG feeds or G-tube placement in order to be able to provide nutrition. So when we look specifically at the treatment of aspiration, all right, so regardless of how we're feeding at this point, how do we manage the actual aspiration? And you can start with no treatment, right, which if it's really mild and not causing any long-term problems, might be an option. I would posit that if your child is aspirating and you're sitting in this room, we're really unlikely to be going the no treatment option. Probably also not really likely to be going the therapy-only option, but for some kids, either some oral motor therapy or some rehabilitative therapy for swallowing function is successful. But more likely than not, if your child's aspirating, we're going to be talking about both medical treatment and or surgical treatment. Oftentimes, we sort of proceed in a stepwise fashion. I think one of the things that we've learned over time here, actually fairly quickly, is that with aspiration, we want to be a lot more aggressive than we have been. And so we oftentimes will say, if your child's aspirating, maybe you haven't been on any of the medications yet, but probably we're going to talk about jumping to the surgical options sooner than you might encounter other places. So again, no treatment, rarely going to be an option. This is mostly for kids who have more of a drooling problem than an aspiration problem. Therapy options, again, there's some oral motor therapy, some cueing, some mobility things that can be done. This is, again, going to be for kids who have more of a drooling problem rather than an aspiration problem. And there's some situational factors, there's some behavioral therapy that can sometimes be effective. But again, for most of our kids with CHARGE syndrome with significant secretion management problems or aspiration, we're going to be moving pretty much straight away into the medication and or surgical options, right? So medications, they can be really helpful. For about 80% of kids, when you first start these, they're great. You get significant improvement. And so they've definitely got a role in the management of aspiration. And there tend to be the three main medications. I see a lot of people nodding their heads as they look at that list because you may have tried all of them at various points. Right, so Robenal or glycopyrrolate, this is effective in up to 95% of kids initially, right? And the initially is the key in this. What we see over time with Robenal is that you have to keep increasing the dose for it to continue to be effective. You start with a small dose, it works great. After a few months, it's not working as well. We increase the dose, it works great, and you keep kind of having to step it up. But eventually, for a lot of kids, you end up having to discontinue it because as you get to the higher dose, the side effects of the medication start becoming too impactful to continue. And those side effects include dry mouth, right, which is sort of what we're aiming for, right? We're trying to dry up those secretions, but sometimes it gets too dry. And especially in our kids with trachs, we will oftentimes see that to get the dose high enough to dry up the secretions, we make the trach secretions so thick that the trach is plugging all the time, which creates a problem that's just as bad in its own right. So, and then you can also get some things like urinary retention and flushing, which is based on the way the drug works. The scopolamine patch, this one you have a little bit of a delayed response. It doesn't kick in quite as quickly as Robenal does. It's pretty common for this to cause drowsiness. If any of you have ever worn this as a motion sickness thing, like on a cruise or an airplane, a lot of times it's really effective for that because it makes you really sleepy. Then you just sleep through the motion sickness. For some people, it can affect how their eyes function, and it can make it really difficult to accommodate for reading, which is more problematic in older kids, but it can also impair their ability to focus. So in kids who already have some vision issues, that additional impairment can be problematic. And then there's Botox, right? So this Botox is hugely beneficial. So this is a medication, it's just like what's injected for wrinkles, right? It's meant to paralyzes the muscles, and it sort of paralyzes, if you will, the salivary glands. So we'll directly inject this into the parotids and the submandibular glands, and it decreases saliva production by blocking the release of neurotransmitters, all right? So this is a little cartoon of how it works. And basically it keeps the little pockets, the little bundles of neurotransmitter from being able to dock. And if it can't dock, it can't be released. If it's not released, you don't get saliva production. In Cincinnati, this is actually always done by our interventional radiologists. They do it under ultrasound guidance. The studies would indicate that if you do this with an ultrasound rather than just sort of blindly injecting, you get a much better result, and it's much more effective. So when we recommend it here, we're recommending doing it, but it's going to be the interventional radiologists that do it. And it can be pretty effective, and when it works really well. So for about 2/3 of kids, it's really impactful. It makes a huge difference. There's a small number of kids where it sort of works, and then about 1/3 of kids, it really doesn't make any difference. Now, this is when you kind of pool the studies, and in some of these studies, they blindly injected, so what we don't know is, did it really not work, or did they just not get it where it was supposed to be? For most kids, the duration of effect is about 4 months, right? So you get an injection for about 4 months, things are good, and then the effect starts to wear off. So that's one of the big downsides to Botox, is you've got to repeat it. Some of the side effects, you can get dysphagia, right? So in some kids, as the Botox, it can spread a little bit, and it can impact either tongue movement or swallowing. And in some folks, it's a risk for aspiration pneumonia, which seems a little counterintuitive. Then why are we using it for aspiration? That's pretty uncommon. And in some kids, it can thicken the secretions too much as well. Oh, that's not as common as it is with the other medications. So medical treatments are great, but they provide a short-term result, right? These are not permanent fixes. The drugs, all of them, become less effective over time, and oftentimes you have to keep increasing the dose. And as you increase the dose, you increase the side effects. We already talked about some of the side effects of Robenal and Botox, as well as the scopolamine. There have been a few rare reported cases of death, but those have all been in adults. So when either we've run out of medical options, the doses we've had to discontinue because of side effects or because the dose is getting too high, now we're talking about surgical options, right? So we do this sometimes when medications fail. More often than not now, we will oftentimes recommend jumping straight to a surgical option. And if you've got a child with significant aspiration who's starting to have some consequences to the lungs. Because what we've learned is that it's much better to manage this really aggressively up front than to wait for some of the pulmonary complications to develop. So what are the surgical options? I will tell you here, we primarily jump straight to the third one, which is excision of glands. There are some places that will take it will take the ducts, right? So the little drainage tube that connects the salivary gland into the mouth and reroute them so that they're further back. Great option if drooling is the problem. Terrible option if aspiration is the problem, because now you're just routing the saliva straight back to like a direct conduit to the larynx. So if anybody recommends this to you, I would really question it. Probably not a great option. Sometimes we'll just recommend tying off all of the ducts, right? So we talk about tying off the 4 major ducts. Little higher rate of failure with this, or having to revise it. So generally speaking here, any of the ENTs that you'll interact with are likely to recommend what we call a drool procedure, which is where we I'll go into that more in a minute, but which is where we actually remove 2 of the salivary glands. So when we look at the success rate of these things, again, that relocation one, it's great for controlling drooling, terrible for aspiration. When we ligate the 4 ducts, over time, there's really only about 30% satisfaction, right? So over time, it just doesn't work very well and we end up having to revise it. Tympanic neurectomy is not something we do very commonly. It's where you actually divide one of the nerves that stimulates saliva production, and it's pretty rare that we go to that. But a drool procedure is something we do pretty commonly in kids who have aspiration. So this is where we're going to tie off the ducts from the parotids. And again, the parotids are these glands that live up here in the cheeks. And you can see the duct there. And that duct drains in. If you want to go stand in front of a mirror, most adults, you can see where it opens up. It's right by your second molar out on the cheek. And we actually, through the mouth, go ahead and tie off a little bit of the opening into the mouth. And then we through little incisions in the neck, remove the submandibular glands, or the glands that live underneath the jawbone. This works in almost 90% of kids. So it's got a pretty decent success rate. Kind of the 2 big things that we see with it is because of where the submandibular gland lives, one of the nerves that controls movement of the lower lip runs right over the top of it. And so there's a risk of injury to that nerve, and you can then get a little bit of a droopy lip. Not very common. And then dry mouth, right? Sometimes we dry kids out too much. This is quoted as a rate of 10%. I can tell you I've seen it in one patient in over time where the mouth got too dry. So it's not something that I worry too much about for most kids. There are complications to any surgery, right? When we either relocate or tie off the ducts, you can get what's called a mucocele. That's where you basically get like a little water balloon of saliva that now can't get out because the gland is still produced saliva, but the pathway out is blocked, and so it kind of can blow up and create a little mucocele. And the tympanic neurectomy, again, which we don't do very often, can affect taste sensation. When we talk about other options, in some kids who are aspirating so severely and having terrible pulmonary complications, we may recommend a tracheostomy. One study looking at kids with charge said it was necessary in up to 30% of kids with charge syndrome. It's a little bit older study. I would probably guess this number is a little bit higher when you look at all reasons for a tracheostomy. Maybe 30% for aspiration alone, but generally speaking, we're not doing it for just aspiration, but also for some airway obstruction. The key thing to remember about having a trach is it's not preventing aspiration. So if anybody tells you they're traching your child to prevent aspiration, they're full of it, because it doesn't stop the saliva or the reflux, the material from getting down into the airway. It just makes it much easier for us to manage it, right? So it lets you suction. It allows for better pulmonary toilet, is the term you'll hear us use, which is, you get the secretions up to the trach and you can suction them out. You don't have to rely on the child being able to cough them and clear them. So it helps us keep the lungs healthier, even though the aspiration is still ongoing. So even if your child has a trach, we're likely still going to be talking about some of those medications or one of the other surgical procedures to help control saliva production. This is going to be a more likely recommendation for us to make if your child also has upper airway obstruction, or if they've got chronic lung disease already, because it gives us more management options. The only surgical procedure that we can do that prevents aspiration 100% is what's called a laryngotracheal separation. That's where we actually disconnect the voice box from the trachea, sew off the bottom part of the voice box, and bring the end of the trachea out in the neck. So these kids will look like they have a trach, but the two things aren't connected. So the back of the throat no longer connects to the airway. This is the only thing we can do that's 100% effective in preventing aspiration. It takes away your ability to phonate. You can't talk, you can't voice, you can't cry. You can learn to do some of those things a little bit, but through totally alternative methods. So that's the huge downside to this procedure. We typically will only recommend this if the lungs are extremely damaged, or if there's sort of really no likelihood of recovering some of that neurologic function necessary to talk, and the goal is really trying to protect the lungs. So I wanted to leave some time for questions, to just kind of summarize things. You guys live this every day. Swallowing, feeding issues, super common. I mean, I've yet to meet a child with CHARGE syndrome who at some point didn't have some swallowing issues. They may not still, they get better in a lot of kids over time, but at some point in their lifetime, every child I've encountered has had issues. They're always multifactorial. There's not one single thing, right? It's all those anatomic issues. It's the other medical problems. It's the developmental issues, the cranial nerve issues, and then the fact that a lot of times, you know, you're spending your first few months of life in a NICU not feeding. And so all of those things play into the fact that learning to feed becomes really, really complicated. But I think, you know, when it comes down to it for us, the biggest issue that has to be managed really aggressively up front is aspiration. And again, the goal there is protecting lung function and protecting it early on so that 5-10 years down the road, we're not dealing with the consequences of having impaired lung function, right? That oxygen need, ventilation need, those sorts of things. And the management options really are going to depend on the severity, right? So it's going to look totally different depending on what all is being aspirated or how often the aspiration is happening. So with that, I will gladly take some questions. Or if you have like a specific question about your child and you want to catch me afterwards, that works.